So one of the things that you learn when you study the activity patterns of neurons in the brain is that there is no difference between psychology and biology. All psychology works through biology. When an animal is feeling, its neurons are active. When you turn on those neurons with a biological mechanism, you can make the animal behave as if it's feeling the way that it would normally feel when those cells are active. And we can use that in humans as well. We know that when a person is feeling a certain state or wanting something, or in any specific psychological state, we can see patterns of activity in that person that correspond to that state. And that we can, although it's much harder in humans than in animals, induce those psychological states by causing activity patterns in the brains of humans. So the psychology and biology, they're all one and the same. Now, that's at the level of trying to understand how the brain works. At the level of trying to understand, at the level of trying to treat patients, there is a much more obvious divide between what some might call psychology and biology.
Mm-hmm.
We think of biological treatments as being drugs that we take,
Mm-hmm.
or perhaps brain stimulation methods or electroconvulsive therapy, these treatments that very clearly work on the body, on the brain neurons. We think of talk therapies, cognitive behavioral therapy, psychodynamic psychotherapy. We think of them as psychological therapies because we're ostensibly not doing anything to the body. We are talking back and forth.
But we're using words, so you're saying, what about
But
words and
what-
biology?
But what we know is that those words induce patterns of activity in the brain, right? When I say the word yellow, automatically, neurons in your visual system that normally light up when they see yellow, they increase their activity when I say the word yellow.
Right.
Right? So we know that words actually change the brain. Psychological treatments work through biology. That doesn't mean that in order to make better treatments, we need to focus on the biology. There are lots of ways to improve how our psychotherapeutic treatments work. There's been wonderful studies looking specifically at one psychotherapy versus another try to figure out for any given illness what is the best approach. Those are excellent ways of trying to improve patient care. Other ways would be to try to look at the timing of psychotherapy and whether you need to continue it or not. The same sorts of studies that we would conduct with a biological therapy. How long does one need to be on an antidepressant?
Mm-hmm.
One can also ask how long does one need to be in psychotherapy. To some extent, many of those questions have been answered for both antidepressants and for psychotherapies, but there are still research that needs to be done. That psychology and biology divide, it is, though, artificial when you think about it at the level of neural circuits. Because when I say we can identify and understand very specific neural circuits in animals and try to use that knowledge to improve our ability to treat humans, that doesn't necessarily mean that it's going to be a biological therapy that's going to be best at activating that specific circuit or inhibiting that specific circuit to try to change behavior in humans. It may be that our best way to, say, decrease activity in the amygdala,
Mm-hmm.
a circuit that we know is important for fear and anxiety, it may be that the best way to inhibit that circuit is actually through a talk therapy.
Hmm.
So even though we need to use biology to try to understand what happens when our patients get ill and how to make them better, it doesn't mean that a quote-unquote biological treatment is going to be the best way to use that knowledge to improve patient care. And we have to be open-minded.
Well, I realize you haven't started your tenure yet, but so let's get back to the RDoc. Do you think that in general researchers are aware that this is the kind of matrix that you are looking at and that others in the NIMH are looking at for future targeted therapies? This sort of biology as impacted by words, which you can't test in a bench science kind of fashion because you don't know what animals, that you can't really use it on animals. What kind of research is happening along this? Are you seeing people say, oh, I get where you're going with this, let's devise a study and ask for funding for this?
I think some have caught on, and I think some have not. And I think the people, there's a lot of resistance in the field to confining research to RDoC categories. I've certainly heard from a lot of people who suggest that maybe we ought to allow research that uses RDoC categories and allow other kinds of research that doesn't necessarily try to adhere to the RDoC categories. This is something that I am looking forward to learning more about.
Mm-hmm.
One thing, though, that is important is that we really try to quantify and objectively evaluate behavior in the way that RDoC tries to do. So RDoC is essentially a way to try to categorize behavior into its component building blocks and then try to understand, yes, the biology underneath it, right? But on the one hand, that's really important because if we can identify and characterize the basic building blocks of behavior, we may come up with better ways to diagnose or treat when syndromes that involve behavioral disturbances. So it may be that our diagnostic categories don't work all that well because we've got the wrong basic building blocks of behavior. And if we had the right ones, we could construct better categories. Or it may be that our treatments would be better targeted at specific domains of behavior rather than at specific diagnoses. And I think that's an admirable effort. Where I think we can get into trouble with any system is when we accept it as dogma.
Mm-hmm.
If someone looks at the RDoC matrix, that's what it's called a matrix. If someone looks at the RDoC matrix and says, well, that is the way the brain works, they're going to be wrong. Because we are trying to do this, but we're not terribly good at it. The brain is incredibly complex. It's so complex that our own brains have trouble understanding it. It's probably impossible that we really understand it. But if we can get to a better categorization of what goes wrong in the brain, be that through an RDoC sort of symptom or domain-based approach, or through some other approach, it will help with patient care.
Okay, so speaking of RDoC, when your predecessor, Dr. Thomas Insel, was the director, he was one of the major proponents for the creation of the RDoC. And there was an awful lot of pushback, and particularly, all of us in this involved in the field will remember the tension between whether to use RDoC criteria or DSM criteria and so forth. I'm wondering, did he give you any advice? Have you spoken to him? And did he say, look, here's the bigger picture with all this. Here's where, we can have common ground. Here's where it's going to go eventually. Tell me what insights he might have shared with you about that.
So I did speak to Tom, actually several times. The first time was just when it was the possibility of me even applying for the job first came up. I wanted to know more about what the job was like, and I spoke with him back then. I've spoken with him a couple times since the announcement. We've spoken about a lot of things. We have not spoken directly about RDoC. And I think that's born of Tom's care and willingness to have this idea evaluated sort of independently. So to his credit, he has not tried to say, oh, you've got to keep RDoC, or for that matter, oh, you've got to keep anything.
Okay.
He's given me wonderful advice, and the best piece of advice he gave me was to take that first however long, 6 months, a year, and just listen. And that's really what I intend on doing. So, I've obviously already given you some ideas that I have about how RDoC does fit into things or how important it is or could be. But at the same time, I think what I really need to do is learn and spend a lot of time trying to figure out what people in the field, how they're using it. How has it worked when they've used it? How has it not worked? And I think the integration of DSM and RDoC, or lack thereof, is something that I really want to look at. RDoC is not meant as a diagnostic system, right? It's meant as a way to target research into behavioral domains that we can use to explore biology. But that doesn't mean that it won't or can't inform diagnosis at some point. And so how does one make that transition When will we know enough about domains of behavior that we can then try to refine diagnostic criteria? I don't know, but that's something I'm interested in learning about.